My name is Patrick Farley. I work at the University of Mississippi Medical Center. This is going to be the second part of the talk on CTA of aneurysms. Objectives: it's important to be able to describe the patterns of subarachnoid hemorrhage, to properly describe the aneurysm in the radiology report, to know the common locations of aneurysms, to understand the mortality associated with subarachnoid hemorrhage, and to know the basic treatments for aneurysms and complications. Perimesencephalic hemorrhage is important to know about. So questions: what is this? How often will we find a source of bleeding? What's the prognosis? Perimesencephalic hemorrhage has to do with subarachnoid bleeding that's confined to the peripontine and perimesencephalic cisterns. It's thought to be due to a ruptured vein, not from an aneurysm, and we'll only find a source of bleeding in about 5% of these patients. They have a very good prognosis, and rebleeding is very rare. This is in contrast to aneurysms. When we talk about aneurysms, most commonly we're referring to the berry aneurysm or saccular aneurysm, and that's the majority of them. 80% of the patients with a spontaneous subarachnoid hemorrhage have ruptured a berry aneurysm. 90% of these are located in the anterior circulation, and 10% are in the posterior circulation. We'll go a little more in depth into locations. Determining the site of rupture of an aneurysm is extremely important. Initially determining this can be helped by looking at the pattern and distribution of the blood products on the non-contrast CT of the head. So anterior communicating artery aneurysms comprise 35% of aneurysms, and you're going to get hemorrhage in the region of the interhemispheric fissures. You can certainly get intraventricular extension. Posterior communicating artery aneurysms also comprise approximately 35%. You'll get hemorrhage in the sylvian fissures. Middle cerebral artery aneurysms comprise 20%. Hemorrhage is going to be a little bit more lateral in the sylvian fissures and in the regions of the temporal lobes. Basilar artery aneurysms, you're going to get more hemorrhage in the prepontine cistern. Internal carotid artery aneurysms are going to occur in the region of the sylvian fissures, suprasellar cistern, and extend intraventricularly. Pericallosal artery aneurysms are going to sort of track along the corpus callosum. So if you see a blood pattern like that, you need to look a little bit more distally in the ACA territories. And then posterior inferior cerebellar artery aneurysms are going to be showing hemorrhage in the region of the foramen magnum. When you report an aneurysm, there are certain things you want to include. You want to talk about the size of the aneurysm, and 3-axis maximum size is most useful. You want to try and describe the neck to tell if it's a broad-based neck or a small neck. You're going to want to describe the shape and lobulation, so if it's a single lobule versus multilobulated. The orientation of the apex of the aneurysm, you're going to want to describe that. If you see small arterial branches in the region of the aneurysm, it's important to describe those so that the surgeon knows what could be impacted in the treatment. And certainly if any arteries arise from the aneurysm, you're going to want to describe that because they may be sacrificed at time of treatment. What's the prevalence of aneurysms? In the asymptomatic population, approximately 0 to 9%. And remember that in a patient with aneurysms, there's an increased risk of multiple aneurysms. So if you do see an aneurysm, you want to keep looking to find the additional aneurysms. Don't get satisfied with your search. So part of the reasons why aneurysms rupture is that the walls are abnormal. You have a thickened intima with an absent muscular and internal elastic lamina, and so as the aneurysm grows, it can become irregular and you can get mural thrombus, and then often they rupture from the dome. Risk factors for aneurysms: hypertension, smoking, family history, and then other conditions. So there's a long list of other conditions that can cause aneurysms. It's useful to think about aneurysm hemorrhage in patients with these conditions who come in with subarachnoid hemorrhage. The Hunt and Hess grading system is used to describe the clinical picture of the patient. 0 is the lowest in an unruptured aneurysm. 5 is the most devastated patient who's in a coma. And you can see the other numbers for clinical pictures in between. So clinical signs can also be important in localizing where an aneurysm may be. And so if somebody has a cranial nerve 3 palsy and pupil involvement, what do you need to think about and where do you need to look? You're going to want to consider the posterior communicating artery aneurysm and evaluate for that. Oculomotor palsies with pupillar involvement are often due to compressive lesions, such as an aneurysm, because the parasympathetic nerves travel with cranial nerve 3. This is in contrast to ischemic lesions, which are not going to necessarily affect the parasympathetic fibers, and so the pupil will be spared. Here's a picture from opthobook.com. You can see there's the aneurysm. You can see that it's pushing on the superficial parasympathetic fibers, and so that's why you want to be very worried about aneurysm in a patient with those clinical symptoms. The mortality of subarachnoid hemorrhages can be early and delayed, so immediately you can have massive hemorrhage causing herniations, which lead to death. People will often have an initial hemorrhage, and then if they're not treated, they will get a rebleed with usually worse hemorrhage and worse prognosis. Once the initial hemorrhage is done and treated, you can have delayed mortality, with vasospasm being the biggest problem. That can occur 2 days to 2 weeks out. Once you get vasospasm, you can get infarcts from that. Those can swell and cause mass effect. And often the vasospasm is related to the total volume of subarachnoid hemorrhage at the time of initial bleeding. So to treat aneurysms, you can coil them, but disadvantages include that the aneurysm can reform after coiling, and that's why we do follow-up studies. You can get strokes certainly at time of aneurysm coiling. Alternatively, you can clip the aneurysm. You're going to have to do a craniotomy for that. And in general, you don't need to follow up. Clipping is felt to be definitive treatment. If somebody ends up with vasospasm, to treat that, you can go in and give intra-arterial calcium channel blockers to vasodilate those vessels to try and prevent the problems of infarct related to vasospasm. So as a recap, remember that not all subarachnoid hemorrhage is aneurysmal. There is perimesencephalic hemorrhage that we talked about, and of course there's always traumatic subarachnoid hemorrhage. You want to use the location of the hemorrhage on the non-contrast CT and any neurologic symptoms that are provided to you to pay extra attention to areas where the aneurysm may be located on the CTA. Remember that the mortality from the subarachnoid hemorrhage can be due to the initial mass effect from the bleed or the ventriculomegaly, or even after treatment can be due to vasospasm, which can cause devastating infarcts. Aneurysmal hemorrhages need to be treated to prevent rebleeding. That's why it's so important that we accurately identify and describe the aneurysms on the CTA so the patient can get the optimal medical care they need.